since I think they comprise the largest proportion of patients, I should be given a little more time, little extra. ALF is a condition associated with high mortality, and liver transplant is the only modality of treatment which has made any significant impact on the survival. Diverse etiology of ALF has already been discussed. It's important to know the etiology of ALF because it's an important determinant of the outcome. And we have seen the different etiologies from India. Almost all series show that viral hepatitis is the dominant cause of ALF in India. And the last series of Acharya, 458 cases, 42% were because of viral hepatitis, out of which more than 50% were because of hepatitis E. But then there is a large group, about 47%, in which no cause was found, and they were called as indeterminate acute liver failure. And they believe that the clinical pattern and the biochemical pattern of these patients resembled those of viral hepatitis. But it was not proved that any one of them had actually viral hepatitis. Compare that to the US data, in which majority of them have acetaminophen poisoning, and indeterminate comprises only 15%. And in them, they try to look for the presence of occult HPV infection. They found none of their cases had occult HPV infection. But they proposed that the probability in these indeterminate could be acetaminophen related, or else it could be autoimmune. So there's a difference in the data from East and West. Hepatitis A is usually a self-limiting hepatitis in the adults. Less than 1% will develop acute liver failure, and responsible for 3 to 4% of ALF in India. The number has come down in the recent series from Acharya is about 1.2%. The prognostic factor which makes the hepatitis A more severe is advancing age, underlying chronic liver disease. The PCR negativity during the ALF is a bad prognostic sign. These patients do not do very well. And in one of the studies, they developed a prognostic model which will predict the need for transplant or death. This was the study on 29 patients with hepatitis A ALF from US ALF study group. And they found that 18 out of 24 were PCR positive, and 6 out of 24 were negative. PCR positive transplant, the PCR positive patient had a better outcome. There was transplant-free survival of 77.8%, whereas PCR negative patient had only 16.7%, meaning thereby the host immune response is responsible for clearing the virus and is responsible for injury. They also studied the entire HIV genome, and they found that the nucleotide substitution, which was earlier thought to be playing an important role in development of ALF in these patients, did not play any significant role. Same group of patients, 29 patients, the outcome of ALF in these patients was that 55% recovered spontaneously. Spontaneous recovery is common in hepatitis A ALF. 31% underwent transplant, and actually 4 of the patients died. And based on the clinical pattern and clinical criteria, they devised the prognostic model: ALT of less than 2,600, creat more than 2.1, need for pressors, and need for intubation. Now, if you have 2 or more of these criteria, it has a good sensitivity, specificity, and positive predictive value. And they thought that this predicted the need for transplant and death much better than King's College criteria or the Merck criteria. Coming to hepatitis B and ALF, develops in about 0.1 to 1.2% with HBV infection. It's common in Asian countries and Eastern European. In India, the reported prevalence of HBV as a cause of ALF is about 11 to 27%. And there has been a progressive decline on HBV ALF in the West from 30% in 1970s down to 8% in 2000. As mentioned by Dr. Zeman, it could be a de novo infection. Hepatitis B could be a de novo infection, or it could be a reactivation, which again could be spontaneous, or it could be chemotherapy or steroid induced. Whatever may be the way it develops, the HBV ALF is due to massive immunological attack on the infected HBV hepatocytes. Hepatitis B reactivation is extremely important in Asian countries as a cause of ALF, and can occur in a variety of ways. It could be spontaneous when the patient develops a mutant virus. It could happen because the patient has developed drug resistance, or you have withdrawn the antiviral drug. It could happen with HIV co-infection. Solid organ transplant patients who have hepatitis B infection can undergo reactivation. Finally, and very importantly, chemotherapy or immunosuppressive therapy may predispose to reactivation. And a meta-analysis of 14 studies in hematological malignancies, cancer chemotherapy, the average reactivation rate was 33%. Hepatitis occurred in 33%, 7% died. And the risk factor for such reactivation were found to be male gender, young age. Very importantly, HPV replication at baseline. If you have a DNA levels of more than 20,000 international units, then more likely to have reactivation. Certain chemotherapies are more predisposed to develop reactivation. Corticosteroid chemotherapy is using corticosteroids along with other chemotherapeutic agents, or else rituximab. They are especially prone to develop reactivation, and so is true for bone marrow transplantation. Reactivation would undergo 3 phases. Firstly, there will be a phase in which there will be HBV DNA which will increase, and then there will be a phase of hepatitis where there is increase in the liver enzymes. And this is the phase when fulminant hepatic failure can occur. And if the patient survives this phase, will enter into the phase of recovery. How do you treat them? Actually, the prophylaxis is much better than treatment of reactivation. The results of actual treatment is not so good. And when you should start 1 to 2 weeks prior to starting chemotherapy and should be continued till 6 to 12 months after treatment. Antiviral drugs, lamivudine or other more potent nucleoside analogs would be the treatment of choice. There's no problem in treating the reactivation prevention, but there is a problem in the treatment of severe acute hepatitis B in patients with antiviral drugs. There is some debate going on. There was the trial published by GB Pant group, 71 patients with severe acute hepatitis, in which they randomized them to lamivudine or placebo, and they found that lamivudine did decrease HPV DNA in their patient, but it failed to significantly improve the serum bilirubin, ALT, INR as compared to placebo group. So they concluded that lamivudine therapy does not alter the natural history of severe acute hepatitis B, but none of their patients actually had ALF. But there is other school of thought which says that antivirals are important in the management of severe acute hepatitis B. Use of lamivudine is standard of care in patients who are likely to undergo transplant. Patients in lamivudine who have been put in lamivudine in this group often will show remarkable improvement in INR, bilirubin, and ALT values. And a large series of 37 patients, hepatitis B, ALF, they found these patients were on lamivudine and their survival was around 78%. This was compared to 20% survival in the historic control, a marked difference. 2 other Chinese studies also showed that lamivudine is much better than placebo in severe acute hepatitis. It reduces mortality. But this benefit will be obtained only if you start lamivudine early, before the stage of systemic inflammatory response syndrome sets in. Once the phase of systemic inflammatory response sets in, then there is no difference between lamivudine and placebo. Usual recommendation: patient with fulminant or severe hepatitis must be evaluated for liver transplant, and these patients would benefit from nucleoside analog treatment. Entecavir or tenofovir should be used. Duration of treatment: at least 3 months after seroconversion to anti-HBs, or else 12 months after anti-HBe seroconversion without HBsAg loss. Diagnosis of HPV and ALF would require doing both IgM, anti-HBc, and HPV. May be negative in about 55% of cases. You will have to do DNA to test to look for occult HPV infection, and for the prophylaxis purpose also, you also need to do both HBsAg as well as anti-HBc. Looking at the comparison of prognosis of hepatitis A ALF and hepatitis B ALF, a study was published in American Journal of Gastroenterology in 2003 and showed that the spontaneous transplant-free survival was much better in hepatitis A, 69%, as compared to hepatitis B, although there was no significant difference in the clinical and lab parameters at the time of admission in the 2 groups. So this different spontaneous survival is a nature of hepatitis B infection. Coming to hepatitis E and ALF, most frequent cause of acute viral hepatitis in developing countries, and all series report that hepatitis E is the most common viral etiology in India, 23% in Acharya series and 38% in Khuru series. And generally, the attack rates are high in young adults. It's usually a self-limiting disease, but when it occurs in pregnancy, it's more severe disease. Attack rates in pregnancies are high, 8.8% in first trimester, 19.4% in second, and 18.6% in third. Compare that to non-pregnant women, it's 2%, 2.8% in men. So pregnancy, high attack rates. Not only that, ALF develops more commonly in pregnant ladies, 22%, as compared to non-pregnant ladies or men. In the Kanpur epidemic also, 79,000 patients got involved. There were 48 deaths, and 13 deaths were in pregnant women, which was much more than expected. 2008, hepatology, there's a publication by the AIMS group. They had, by that time, 1,015 patients, and they found that hepatitis E was more common as a cause of ALF in pregnant women as compared to non-pregnant women or men. But the clinical feature, disease severity and mortality of ALF was similar in three groups. So once the phase of ALF sets in, there's no difference in the outcome. But pregnant ladies are more likely to have ALF because of hepatitis E. There are various other series which have reported the high prevalence of FLF in pregnant ladies, except last two. This one is an Egyptian study, whereas the last one is a study from Jayanti group in South India. This is a study of 220 pregnant ladies published from G.B. Pant and Lady Harding College. The acute hepatitis was caused by hepatitis E virus in about 60%. ALF occurred in 55% of HEV, whereas only 20% in non-HEV pregnant women. The maternal mortality with HEV was 41%, compared that to non-HEV infection 7%. Compared to that, HEV infection in Egypt is believed to be a benign disease. Prevalence of anti-HEV is high in rural communities, but severe hepatitis is extremely rare. In a large series of pregnant women, anti-HEV positivity was 84%, but no case of acute viral hepatitis. Why hepatitis E is more severe in pregnancy is not known, but immunological and hormonal factors are supposed to play an important role. There is a depressed cell-mediated immunity during pregnancy. T cells are decreased, CD4 count is decreased. The shift of Th1 to Th2 response, the low cytokine production. Hormonal factors such as progesterone, estrogen, HCG increase during pregnancy, which have a suppressive effect on CMI. I also believe that steroid hormones can cause lymphocyte apoptosis through NF-kappa B, and experimental evidence to suggest that if you lack P65 component of NF-kappa B, there would be widespread apoptosis. A human study was performed by Maulana Azad group, in which they showed that pregnant women with ALF had almost absent P65 component in mononuclear cells as well as in the liver. And they said that P65 absent from NF-kappa B was responsible for liver damage. Acute hep C causing ALF is rare. Acute hep C is usually asymptomatic. 17% develop symptomatic acute hepatitis. Jaundice occurs in only 10 to 20%, and about 10 to 50% have spontaneous clearance. Fulminant hepatitis is extremely rarely reported from West, but has been reported from Japan and China. The initial report from India showed that HCV-ALF is in about 2 to 4%, but they were based on second generation ELISA testing of anti-HCV. We require more recent data to show the exact prevalence of HCV as a cause of ALF in India. For the diagnosis of HCV infection, you would require not only presence of HCV RNA, but you should be able to demonstrate the seroconversion from anti-HCV negative to anti-HCV positive. It's very difficult. HTV, defective virus, requires HPV for replication, can occur as co-infection or superinfection. But whenever HTV is present in hepatitis B, it induces a severe hepatitis, and these patients can have hepatocyte necrosis and liver failure, leading to fulminant hepatitis. In the reported literature, it was 3 to 5% of ALF in our country. In conclusion, acute liver failure due to viral hepatitis is common in India and rare in West. Hepatitis E is the most common viral etiology. Large percentage of ALF cases have No identified etiology. It has been believed, it's presumed that in our country it's probably because of viral hepatitis, but it's not. As Dr. Manav said, there are other possibilities like autoimmune hepatitis are a possibility in this indeterminate group. Hepatitis A virus is uncommon cause of ALF in India. Advancing age and underlying chronic liver disease may be predisposed to ALF due to hepatitis A. PCR negativity is associated with worse outcome in hepatitis A ALF. Hepatitis B as a cause of ALF is common in Asian and Eastern European countries, and hepatitis B ALF can occur because of de novo infection, or it could be a reactivation. And reactivation of hepatitis B can occur in a variety of circumstances and can be easily prevented by nucleoside analogs. There is increasing evidence of beneficial effects of nukes in severe acute hepatitis B. Finally, hepatitis E is usually a benign disease but has disastrous consequences in pregnant ladies. Attack rates of hepatitis are high during pregnancy, and pregnant ladies with hepatitis E often develop ALF. But once ALF develops, the probable outcome is same. Mechanism of severe liver injury is unknown. Immunological mechanism or hormonal factors may play an important role. Acute hep C is a rare cause of ALF but has been reported from Asian countries. And other viruses which can cause ALF include HSV, varicella zoster, CMV, and Epstein-Barr virus. Thank you for your patient hearing.
Thank you, sir, for that excellent overview. Now the talk is open for questions and answers.
I really enjoyed. Yeah, I enjoyed your talk. The one thing that just I want to know from you, and I believe that the mortality in pregnant females because of the HEV-related acute liver failure is high only in the, I would say that epidemic setting.
Yes.
But not in the
Not in the
sporadic.
sporadic.